well, good afternoon, everyone, and welcome back. Sorry for the technical difficulties there. We are indeed back. It's ironic, I was telling our guest about all the high-tech and enabled stuff we have here, and he was all very impressed until about 5 minutes ago, so hopefully we have to restore his faith. So it's my pleasure to welcome you to the ACCEL special discussion today, and to introduce our speaker, Professor Omar Rahman, who is the Vice Chancellor of the Independent University of Bangladesh. I've known Omar for many years, for over a decade now. He received his undergraduate degree from Harvard University, his medical degree from Northwestern, did his residency in psychiatry back at Harvard University at the Brigham, and did his PhD in theology also at the Harvard School of Health. I joke with him that if he hadn't gone to Northwestern, I just have to name one institution and say he got 5 things. He left for Chicago for a short while. He was a professor at the Harvard School of Public Health before he got recruited out to head up their School of Public Health at IUB, the Independent University in Bangladesh. And after that, he rose to the position of Vice Chancellor, which is essentially the equivalent of our university president. His roots remain in research, and he is the local site director for a very large multi-center longitudinal cohort study called PURE, which he will tell you more about. They've also developed several interesting innovations in data collection in the field, utilizing high technology, mobile phones, and students, and Omar will tell you a little bit more about that as well. So with that, please join me in welcoming Professor Rahman.
Thank you, Omar. I always feel like I'm talking to myself. The same first name. But it's a real pleasure to be here, and I'm really happy that so many people are very busy to come and hear what I have to say. And as Omar pointed out, that forward arrow. I'm going to start off by talking about an international cohort study called PURE, the acronym respective urban and rural study, which is we'll start off telling you a little bit about it and the kinds of information that we've gotten from PURE and the report. It is billed as the largest study of risk factors for started off as cardiovascular disease, but it's really looking at a whole set of chronic diseases. My assistant got the number, and he's overly optimistic. It's 200,000 people now. And it's a consortium of currently now 24, but started off with 17 countries, with basically the 2 largest contributors are India, which has about 40,000 individuals, China, which has another 40,000. Most of the other countries have between 3,000 and 5,000 Bangladesh. This is what we call a cohort study. So these are individuals. So when we're talking about 200,000 individuals, these were people who were identified at a certain point in time. Extensive information was gathered from them, and then we have followed them over time and what they've done. The basic impetus for this study was this growing realization that most of the data that we have on chronic diseases is from the developed world. Because, for the longest time, it was felt that for the developing world, it was all infectious diseases, and that's where all the mortality and morbidity was. And of course, as we all know, that has changed dramatically in the last couple of decades. So the idea was that we needed to create a database, because almost everything we know about heart disease or diabetes, or almost any kind of chronic disease, comes from studies like the Framingham Heart Study and other studies which are basically based in Europe. And there was some sense that perhaps the picture may be somewhat different in different parts of the world, reflecting genetic diversity, differences in diet, differences in tolerance levels for various kinds of issues. The other sort of impetus was that there's a massive urbanization going on in the developing world, and people are moving from rural areas to urban areas, and there was this concern that this, along with this urbanization, will come along adverse lifestyle impacts, more sedentary lifestyle, a high fat, as these countries also became affluent, consumption of fat will go up, consumption of a lot of things which lead to perhaps an increased risk for a variety of chronic diseases. And so the idea was to see whether we can map this and over time. So it was built as an observational study, and as I said, roughly 40% of 40 to 50% of the total sample comes from China and South Asia. But every continent is represented. For example, in North America, we have Canada. We don't have the US. Canada is in fact the coordinating site. This is out of McMaster, the population center there. Dr. Salim Yusuf, who's the director of the project. In South America, they have Brazil, they have Argentina, they have Chile, and they have Colombia. In Europe, they have Poland and Sweden. In Asia, there's a whole range of countries like India, China, Bangladesh, the whole of South Asia. Bangladesh, Pakistan, they have Malaysia. They have in the Middle East, they have UAE. In Africa, they have South Africa, they have Zimbabwe. And as I said, more countries are joining. And the whole idea was to get a spectrum of population which spans both cultural and socioeconomic differences. Because so much of what we know comes from fairly homogeneous groups. The third was that perhaps we are making inferences which may not hold for more heterogeneous people. Okay, so the first round started off around 2007, which was the baseline. I'll describe the Bangladesh experience, but basically the other, and there's some differences of what we did in Bangladesh relative to the other countries. The main difference being that Bangladesh was a true population-based study, where many of the other countries were essentially there was a catchment area for a clinic, and people would come to the clinic and so there's some with regard to that. And so in Bangladesh, initially the idea was to have two distinct sites, a rural site and an urban site. The rural site was chosen in an ad hoc fashion. There was one particular, there are 64, Bangladesh is 160 million people. Each of the districts, there are 64 districts, about 2 million. A particular district was chosen primarily out of convenience, to be perfectly honest, because we needed to be close to the university and we needed to transport biological samples, so it needed to have access to a fairly sophisticated facility where biological samples would be processed and so on. But once we decided on the particular district, we did a stratified random sample of picking 30 villages. The district itself was picked purely out of convenience, but once we did that, there are, basically the structure is a district has certain sub-districts, certain number of villages, and we did a true stratified random sample, and we ended up with what we call communities, but they were basically villages in the rural mapping. Now for the urban sample, we chose the capital, and here we did do a stratified random sample, using a grid of the capital city, which is Dhaka, which has 20 million people. Very, very large mega. Dubious distinction of being the 6th most populous mega city in the world, and is likely to become the 3rd most populous given its rate. So, very different cohorts. It was 1,500 households rural, 1,500 households urban. And what we did initially was we went in there and we looked at, we did a household, we identified, we did a random, we did basically all the households in those communities. We went into the household and we did a complete household roster. We got information on everybody in the household, but the more detailed questionnaire was applied to adults over the age of 30, between 35 and 70. The argument being that our focus was on chronic diseases. That's where the money partly constrained by resources. Our sample size is limited to all adults between 35 and 70 in the households that were. And once we went, and we did, however, do a complete household, so we know who's there in the household. So there is some modest information on everybody in their household, but the more detailed information is. And what really distinguishes this survey from others is its sort of comprehensiveness. Not only did we collect extensive information, which is survey information, demographics, age and cause of death, household possession, indoor housing, environment. I mean, you name it, we collected it. it's a very, very comprehensive questionnaire. But in addition to the questionnaire, and you could see all this stuff, anything that could have vaguely any kind of health-related impact. We also collected biological samples. We collected blood samples from every single about 20 milliliters of blood, which were processed for lipids, blood sugar, and we've taken consent to do potential DNA studies. But so we have banked them. We have consented to biological markers. But right now the focus is on really things that we can measure fairly straightforward manner. In addition to blood, we also took urine samples. Particularly, we were wanting to look at sodiums. A series of papers have come out in the journal looking at the data from which we validated with a smaller group using. We also, so it was urine and blood. We also did ECGs on every adult. We did spirometry on every adult. We did anthropometry on it. We did, I'm trying to think of what else. I think that's basically it for the first round. And so on an individual level, it's a very, very comprehensive database on anything that will have some impact on it. And in addition to, we also have it backed up by what we call the objective measure, because the questionnaire stuff is all self-reported. The measurements are, of course, real measurements. The challenge here, and I should mention that this is the first time that we were doing all of this in the field. So it's not like they're coming into a clinic and you're having them stand on a weighing scale or you're doing an ECG. We had to actually do portable ECG machines, take them out there, draw them, and we had to. The real trick for us was to transport the blood to make sure that it, didn't spoil all the way, because it's basically 2 hours from the city. We had to develop basically that infrastructure. We would transport the biological samples, keep it on ice, bring it, and then store it. And we have them stored in -80 freezers, so they've been actually about, it's a double sample. One sample we have in the university is now being stored for about almost 10 weeks. This is our story. The other samples have been sent to Hamilton, Ontario, where McMaster University is for processing. So lots of biological samples, lots of measurements on a very large. Okay. In addition to the usual biological risk factors, we also were interested in looking at a whole range of things like access to healthcare, cost of healthcare services, issues about lifestyle changes, what they call the knowledge about various preventative modalities, how much do they know about nutrition. We also did complete food frequency questionnaires. This was a very, very, there's lots of information, and several papers have come out looking at, data on food frequency questionnaires, dietary patterns as a particular risk factor. And, all right, let me talk. So this is just to summarize. So very large cohort. So what distinguishes PURE is that it includes samples from 17 different countries originally, so it's a very heterogeneous group. It's very large. It's 200,000 people. So almost anything you do on 200,000 people, significance of that draw inferences which are very robust. And there is a hugely comprehensive set of data. The real value of the PURE study is not in the cross-section, because that was done all in the first round. Since then, we've done basically follow-ups on a 3-year cycle. And the follow-ups basically, and here's a particularly interesting innovation, focus on what we call extensive verbal autopsy. These are not just autopsies of people who died, because mortality is still fairly rare. We are actually trying to get a comprehensive record of all events, MIs, strokes, and any kind of. And there was a lot of skepticism initially about whether you could collect valid data in societies where you don't have a lot of documentation. And clearly the countries that were in Europe and Canada, you would have hospital records, and if you said that did anyone get a diagnosis of cancer in the last 3 years or have an MI, and you would be able to validate that using actual hospital documentation. Now the really interesting thing was, did you do it in countries which had fairly low access to healthcare, so they wouldn't have more. And we've developed verbal autopsy protocols which have been tested out in various parts of the world, which seem to suggest that we can get a pretty good fix on, an MI, develop some symptoms which are, even things like heart failure. So they're very sort of detailed sort of approaches. And what happens is when you have the verbal autopsy, this information is collected by interviewers who are not physicians. All of the verbal autopsies go to what we call adjudicators. We have 3 physicians who independently code them, and they give a probability of high, medium, or low for the particular diagnosis that is being made. And then we have a process of adjudicating. If you have 2 people who say that it's MI and one person doesn't, we have a way of then these adjudication reports come to our Canadian side, where another group of independent people code. So there is a kind of fairly involved, fairly standardized way of coming to some sort of conclusion on the diagnosis. So this, I think, is actually a very big innovation. Is this attempt to fix a diagnosis without, depending on documentation. The usual, in many cases we did have documentation, but in cases we still gave a sort of a probability score that. All right, so this has been, as I said, has been going on since 2008 with the first round. We've done a second round in 2011, and we're doing the third round right now. There are several aspects of this study which are interesting. Mainly, these studies are very, very expensive. And what was innovative about the study was not only the fact that it was being done in so many different. What was innovative was this arrangement where the individual centers agreed not to charge faculty time or investigator salaries to the project. They just got funding for doing the field work. The quid pro quo was that this would generate such a massive data set, and you would be able to get papers in the best. And this is in fact what's happened. But this is itself an interesting innovation in terms of funding these. This study, if we were truly costed out, would have cost tens of millions of dollars. So many people involved, and if you had to pay for their faculty time, so each institution agreed to sort of pro bono sort of contribute everything other than field costs. The field costs were just the costs of collecting the data, and the equipment was provided, like spirometry things, and blood tests were, of course, you had to cost them out. So this is another interesting model of doing very large-scale studies on fairly modest funding. Now, of course, it only works if everybody's on board and if they are willing to contribute. And it's not always going to work in many settings. But this is something to be, to consider. That we often feel that you can't do a lot because it's expensive. Overhead rates are huge. Now, one of the most, I think, results that have caused the most debate in the medical literature coming out of Cure was a series of papers that came out in the New England Journal of Medicine in August of last year, looking at urinary sodium and potassium and its impact on mortality and cardiovascular. And what was interesting was that the conclusion was quite different from the American College of Cardiology guidelines on what is an. And this caused a huge debate. There was an accompanying editorial from the University of Alabama. There was a series of 3 articles. Back. 2 of them were from the Pure study. One was actually another meta-analysis, which actually suggests that the current guidelines are way too stringent. And the current guidelines seem to indicate that there's a linear risk. The more sodium you take in, the higher the risk of cardiovascular. our data suggests that there's kind of a J-shaped curve. There is a point, there's a sweet spot, which is between 3 to 6 grams per day. Anything lower than that also raises your cardiovascular mortality. Anything higher than that. And there's quite a bit, I have to be honest, there's quite a bit of controversy about these results because they go against the grain of what has been received historically. And the argument from the pure group is that all of the previous data came from essentially homogeneous cohorts in the US and in Europe, mostly from men. There were issues about whether the tolerance for salt is actually different ethnically. One might, reasonably assume that people have different sort of genetic propensities to tolerate salt. They might have different environmental propensity. So our data seems to suggest somewhat a different, more complicated picture than the current guidelines, which suggest a linear risk. Now, it has huge implications because it turns out that, as all of us know, it's very difficult for people to restrict salt. And this has been quite depressing for people, that even for nutritional advocates, that you tell hospital patients that you've got to cut down salt, and people say, can't do it. I mean, there's a point beyond which it's just not viable. So this suggests that we have a little bit more leeway, at least that the risk is somewhat more heterogeneous. Okay, other papers that have come out, this is from JAMA. Interesting data, not too surprising, but it's nice to have it documented. This is data, remember, from large groups which are in the developing world, that about 45%, roughly about half of people with hypertension are aware of the diagnosis. And only a third of those who were treated were being treated adequately. So clearly there's a treatment gap. First of all, there's a clear identification gap. You're talking about tens of millions of people who don't even know that they have hypertension. So the first public policy kind of conclusion is that we need to do a much better job of identifying and even those who are aware of it, the protocols are not standardized. There's a lot of ad hoc prescribing. It's not clear that people are getting even good care. And the nice thing is that most of these drugs are actually easily available in development. Not that they're not available. They're also quite cheap. It's just, I think there's an information gap, there's a standardization gap, there is this whole thing. And to some extent that's also true in the US. I mean, we know that treatments are not particularly standardized. And there is now a push towards having the large healthcare systems are trying to put in algorithmic sort of approaches, saying that given these guidelines, this is how to approach it. So this suggests that there's a huge need for identifying hypertension and a huge gap in treating hypertension. Okay, not surprising. This is again another paper out from JAMA, and again the way they've looked at this data is divided up the 17 countries, now 24, into high income, middle income countries. This was looking at whether people, there was this issue that once you've had a MI or a stroke, do you change your behavior? So there was a lot of, there wasn't very much data, but people seem to suggest that, this sort of kind of a warning, and people make changes in their lifestyle, and the hope was that people do better. Unfortunately, our data suggests otherwise. And remember, we were following the cohort, so we knew people who had events at baseline, and then in subsequent rounds, we wanted to see behavior, both in terms of nutrition. And unfortunately, what we found was, despite having been told, it's not that these people were not given information about it, but usually it was to the extent that they would have a stroke or an MI, they would go to the doctor, would say you've got to walk more, eat more fresh, vegetables, and unfortunately, none of that seems to stick that much. So it's not that easy to get people to change behavior, even after they've had it. Then supposedly is I need to. what is interesting is that, for a long time people thought that poor countries, because they were largely rural, would have healthier lifestyle. They would have nutrition, and unfortunately, again, the data seems to say, again, double whammy. Their lifestyles are in fact not better, not more healthy, and they also have more access. So, you're talking about. Okay, this is a sort of in the same vein. This came out in the Lancet, looking at how widely prevalent are use of commonly used drugs to address hypertension and cardiovascular disease, and not surprisingly, huge variation. And the lower end of the spectrum, the poorer countries, much worse. Not that much access. Okay, I'm now going to switch. So before I move on to another data collection has certain innovative characteristics. So PURE, to summarize, is a kind of a conventional large cohort study. What makes it distinct is that it has a very, very large international, so that is an advantage. Lots of interesting stuff coming out, and every year more and more papers are being published. And I think the real value of these kinds of cohort studies is that heterogeneity matters, that you need to think about propensity for risk is not the same. And drawing inferences on both care and prevention, looking at data from homogeneous cohorts, I think is a portion. So I think that's the sort of the big message, is that most of the data that we have about medicine, about healthcare, come from largely developed world. There is a very underdeveloped database for the majority of the population. So that's, I think, the big message. Some things are the same. It's not biology has a huge impact, but it suggests that diet, lifestyle, all of these things which are socially contextual affect, not only modify the risk, but also modify who does well. Now, but before I move on to my other part of my presentation, I'd like to open it up for questions, and this is just a very brief overview. There is a website for PURE where you can go and they'll give you the list of all the papers, and some of them are open access, some are not, but you can at least topics, and more papers are coming out here. The PURE cohort is continuing, as I noted. We are in the third round, and it will continue as long as we can. Questions, comments, criticisms? Yes.
Well, first of all, congratulations on the development to you and the team at McMaster, my good friend Salim Youssef, and everybody that developed unbelievable cohort study. And it's just the kind of that needs to be done. It's almost unimaginable putting together 200,000 people. I have two questions. One is much simpler than the other. The first question is, how are you handling biospecimens on so many people? Where are they all going to be stored? And there, if you want to do genetics, you're going to have to raise a substantial amount of money, no matter what are your thoughts about that. The other is, how do you deal with bias? Because as you're well aware, size does not overcome bias. And so, truth be told, in full disclosure, I'm on the American Heart Association SALT Task Force, and we were not entirely happy with PURE. So the problem there is I think with the J curve. First of all, I should say that there was a linear relationship between salt and blood pressure, and we'll agree with that. J-shaped curve on events. I think the problem there is that there's a strong correlation between how much people eat and their salt content. When they get sick, it's not a matter of going on a low salt diet; they just don't eat. And so there's been a lot of concern that that's the explanation for the J curve.
So reverse causality, basically.
Right, reverse causality, exactly.
Okay, let me address the first question. Where are these things stored? They're being stored at, well, basically they were dual samples. So in the Bangladesh, I can talk about the Bangladesh case, but it's the same everywhere. But not entirely. I mean, India and China did all their own analyses. So and they are basically 40% of the sample. So there's like 40,000 people from India, 40,000 people from China, and all of the blood samples are stored and analyzed. There are about 5 centers in India and 5 centers in China. What we did in Bangladesh, which is true for the smaller countries, we did a dual sample where we actually kept half the aliquot and we stored them in -8 freezers. And partly it's because we are still looking for, that's the whole thing. We've got to generate some funding, try to analyze these. But the other half was sent to Hamilton and at McMaster, and that's where it's they have these huge data, the storage facilities. They've raised quite a bit of funding to both store it and more and more. They're going to have to get more funding to do subsequent studies. You're absolutely right. All the DNA centered studies are going to have to be made in the future. But we do have the sample. The hope is that we can generate enough interest and get enough funding. Is that a kind of answer?
That answers that question.
Okay. Second question is a much trickier question. And the question is there
You don't have to
bias?
answer it if you don't.
I'm sorry?
You don't have to answer it.
No. I'm an epidemiologist, so as I said, the only thing that I tell my students is the first thing you think about in research is bias. If it's too good to be true, it's usually too good to be true. And you're right. I mean, one of the things that bedevils these kinds of studies is that they are voluntary. That's one bias that we can't do anything about. We can't force people to give blood samples. But interesting enough, the urine samples are pretty, we didn't have that much of an attrition in Bangladesh. Partly people are very cooperative, collaborative, and particularly urine is much easier to collect than blood. So to the extent that the SWORD studies depend completely on spot urine samples, and there's been a lot of concern about whether the spot samples are actually predictive of 24-hour sodium excretion. And the jury seems to be mixed. It's not clear. Some people, they have done validation studies that have been which suggests that it's quite a high correlation, but others are about that. And this issue of reverse causality, because we do have the ability to calibrate them, we know the health status of these people. Because you've got extensive information about the health status. So this is actually an issue that can be addressed. We can look at a more fine-grained analysis and see whether the ones who had very low sodium levels and had high mortality, cardiovascular mortality, whether they had other indications of the fact that that's one way that you could address it. And at the end of the day, that's all you can do, because it's not clear how else you can get around this issue of reverse causality. Other than, and of course, it's a cohort study, so you're following them over time.
Large randomized trials, which is what's the
Yes. Now, that's the next step, and as you know, many of these observational findings tend not to be supported. I can remember a lot of the work from the nurses' health study, the women's health study, and almost, the joke, there's a great New Yorker cartoon which says, finally pizza is great for you, because you have all these studies which show that some risk factor is predictive of mortality or morbidity, and when you do the randomized control, it turns out to. But I think that's you're absolutely right. I'm saying this is not the final word. Clearly, this is an observational study, but it gives us pause to think that the story may be somewhat more complex than just a linear. And I should point out that of the 3 studies in the New England Journal, one was actually a meta-analysis of studies which were different from PURE, which had very similar results. So there is, to the extent that science...
bias is consistent then.
Would be. And you're right. At the end of the day, without the randomized control trial, we're not going to be able to say. And I think this is why randomized control trials remain the gold standard, and I think we need to be careful about guidelines which are based on, because oftentimes these guidelines tend to be more stringent. And you could argue that perhaps it doesn't matter, because if you were more stringent, you wouldn't actually argue that. Unless you really believe the J. If you believe the J, then overly restricting somebody's diet may have actually hurt someone. But I think you're absolutely right. It's an observational trial, even though and you're absolutely right in pointing out that the large numbers don't take away the bias. Because oftentimes people tend to have this notion that, okay, 2,000 people, I'm not so sure, 200,000 people, whatever comes out must be true. And I think that's a very important message to keep reiterating, that bias is independent of sample size. You cannot go past bad design by large numbers. So thank you for mentioning that, and I think you're right. I think at some point we're going to have to do a randomized control trial using heterogeneous population. I think that's the key here, is that we've got to include in our randomized control trial people from parts of the world with different genetic propensities.
Liam and I had an interesting conversation about this at the ESC about the design, and I wondered if it could be done. He convinced me that a randomized trial can be done. He's got some very good ideas about that. Also, he and I agree, even though we were on the opposite sides of that, we agreed, we've been friends for many years, by the way, and we agreed we'd write a paper on this together about what needs to be done to resolve this whole controversy. So I think that's the way to go.
I think the nice thing about the pure data
together.
is that it sparked the controversy. It's people are revisiting this issue, and I think science progresses that way. Something that's thought we received wisdom, people look at it differently, and maybe it'll all pan out that received wisdom was in fact correct, or we find out that. Other questions? Yes.
Do you collect also biological samples during the follow-up for a smaller cohort of patients? Biological or physical samples?
We have the ability to do that. We have so far what we've done is focused on outcomes, and all the biological samples were collected the first round. But part of it is a funding issue, I'll be honest with you. Biological samples are expensive to collect, and we had a reasonable amount of funding for the first round, and putting in grant applications. But it can be done. We are going back to these people every 3 years, and it's certainly something that we do some measurements, but we don't do actually some invasive measurements. Other questions?
If I understand correctly, this was done for the age group 35 to 70. I believe over that age group, we would have another set of standards for.
True. I mean, so the data in the New England Journal are restricted to people between 35 and 70. So we don't know what's happening outside that age.
Are you recruiting new participants each round? What's your recidivism rate?
Okay, very good question. It's actually very, very low. People have expressed some skepticism about that, but be that as it may, because there are 17 different countries. I'll be honest with you, the highest attrition rates have been in Bangladesh. We feel that we are doing this in a way which is, this is off the record. The Chinese data seem to be, they have 99.9% follow-up. No other country has that kind of. It could be given the way Chinese society is organized, and where people, migration is a big problem. People leave, and where not in the rural areas so much, because there's not very much migration. And even for us in the rural areas, we have 98% follow-up. In urban areas, we had 88% follow-up. And we were very surprised when the Chinese came back and said we can follow up 99%. Now, they may well be able to do that because they have a much more controlled society, so they can keep tabs on people. Yes, sample attrition is always a problem. We don't know whether the sick or it's not random censoring. It tends to be that there's a healthy mover effect, so the healthier people are more likely to move. You don't know that. Yes, we need to. Other questions?
And for the lifestyle change, because your data from different countries, maybe for the lifestyle will have a different meanings for different culture, different countries.
Absolutely.
How do you uniform when you do the analysis?
Well, that's a very good question, and obviously, The basic lifestyle changes are the ones that are always promoted. If you're sedentary, you walk more. So that I suspect is generic across all societies. You become more active. With regard to sort of diet, it's always about reducing your fat intake, increasing your. Now there's some, I think the constraints are definitely culturally sensitive. Maybe for example, it may be much more difficult for women to become more physically active in rural societies. It's not a place where women's mobility is unconstrained. So the effectiveness of some of these prescriptions are, I think, very, very strongly influenced by the culture. Telling a woman in a South Asian rural setting go for a walk every day, it's just not going to happen. So you need to think a little bit about how do you do that then? What do you do in societies with constraints? And I think some of the data is making us aware of this complexity that lifestyle is very culturally sensitive. And some interventions work much easier in some, and you've got to be more innovative, creative in coming up with ways of increasing, say, activity level. And that some, particularly women, have certain constraints. And this may be part of the reason where, post-stroke or post-MI, one of the things we want to look at is whether there wasn't much of a change, but was the change even less in women than in men. One interesting, which I didn't report on, was a very interesting finding which we were very surprised about, that in societies which are largely vegetarian, like India, there was this prior hypothesis that people would do better because they're not having very high fat content. Turned out that the amount of vegetables, this is a food frequency questionnaire, turned out not to be predictive of cardiovascular mortality. It was predictive in developed countries, so that, for example, in Canada and Sweden and Poland and even in South America, the more vegetables you reported, you had lower cardiovascular morbidity. Not true in India. And kind of an interesting hypothesis came about that because vegetables in India are not consumed raw, they are fried, and so all of the putative advantages of fresh, because they're not consumed as fresh vegetables. So again, I think it suggests that lifestyle, culture, have a hugely modifying effect on things which seem fairly straightforward. The basic nutritional guidelines: I have more vegetables, have more grains. But it may not always be. It depends on how people.
Well, we might have to leave it at that, given that I think at 2 p.m. we have another group coming in.
Let me just give you a brief, maybe a sort of a headliner on another research effort that my university has pioneered is using students to collect data. We have a national surveillance system of about 10 sites in the country. It's a cohort of 3,000 households, 300 households in each site. And what's interesting about it is that we're using students to collect data using mobile phones. We go back every 6 months. What's particularly, I think, of relevance, and I think with Dr. Chisani earlier, was that this is an ecosystem which allows people to consider research projects which involve primary data collection, in a kind of a plug-and-play method. We are collecting the data anyway. We can go into the field. We go into the field every 6 months. We are happy to have residents, fellows, researchers coming and saying, I want to look at a particular set of issues. Can you put this into the next round? And because we've collected extensive data on these individuals and these households, and also because we follow them up, this is an interesting opportunity for people who want to do this. And also there is this whole issue of RCT. We have an ecosystem where we have 10 different sites, population base. We can do an RCT. And we are set up for that. The structure already exists. So I just want to throw this out there as an interesting possibility for people to interact with at whatever level. Thank you again. It's been a real pleasure.